All right, all right, all right. Let's get my mic check done. We're going to be doing 12 lead EKG. Let's get the PowerPoint ready for you guys. All right, let's share the screen here. How you guys doing? I know a lot of nurses struggle with this EKG. So this is a little more in depth compared to the other slide that I am doing. Um, the other EKG. This one is actually going to be talking to you about 12 lead EKG. All right, I'm just going to do 20 slides in this PowerPoint. All right, great. Are you guys ready? Let's dive right in to 12 lead EKG. So these are some objectives that you will be covering in this class, this 12 lead EKG class. You can see the objective and that's going to read it. You can read that. And this more objectives. You will learn the terms dilatation, hypertrophy, and enlargement. Okay. All right. So when you're dealing with EKG, I need to get this out my way. Oh, come on. I can't see the top of my slide. Ay, ay, ay. When you're dealing with 12 lead EKG, you want to know that there's multiple view of the heart and can provide useful information, including the following things: identification of ST segment and T wave changes associated with myocardial ischemia, injury, and infraction. Also, you can identify the ECG changes associated when a patient is taking different medications or electrolyte imbalance like potassium, magnesium. When you have any changes with those where it's out of control, the strips change, and this is how you're going to learn what exactly those lines mean. You're going to be able to recognize a bundle branch block as well. So some indication for, actually, I would like to go back one. So a standard 12 lead EKG provides view of the heart in both the frontal and horizontal plane and views the surface of the left ventricle. This is the basic from 12 different angles. That's why it's called 12 lead EKG. You need 12 leads to look at all the different angles. Multiple views of the heart can provide useful information, including the following. Okay, and we just went over all of them. Right? I just wanted to emphasize that for you. So when a person have chest discomfort, electrical injuries, known or suspected electrolyte imbalance, known or suspected medication overdose, right or left ventricle failure, status before and after electrical therapy, stroke, syncope, or near syncope, or an unstable patient of unknown cause, any type of dysrhythmic interpretation, you may need to do a 12 lead EKG, which is why it's an indication for use. Okay, so let's go on the layout. The document that you see listed here, you need to know that most 12 lead monitor record all the 12 leads simultaneously. So that means they happen at the same time, but they display them in like a conventional 3 row by 4 columns. That's why you see it say lateral, inferior, and inferior right here. But if you look, you have like, we say 1, 2, 3. Over here, you see it has different names, right? And they go across in 4 columns, right? Column 1, column 2, column 3, column 4. They call this side the limb lead, and this side is the chest lead. Limb, you know when you put the leads on, they go also on your legs. So this is what limb leads mean. And then this is your chest, the ones that we put on the chest. These are usually 6 different leads. You have V1 through V6, but over here you have the AVR, and then you have the AVL, and then you have the AVF. Okay, these goes on the arms and leg. Um, when you're doing the standard limb leads, it is recorded in the first column right there. The augmented limb lead is in the second column. All right, and you already see the chest one is in the third and the fourth column. So what is this all about? You can see that there is a patient here and it giving you all the information. This is a standard strip. I do these in my office. You guys is gonna learn this in the last 2 days in the class, I believe. We're gonna go to the lab that week and we're gonna practice, right? You're gonna string up patients and we're gonna do some EKG on you guys, okay? All right, so the 12 lead EKG provide 2.5-second view of each lead because it is assumed that a 2.5 seconds is long enough to capture at least one representative complex. However, a 2.5-second view is not long enough to properly assess the rate and the rhythm. So at least one continuous strip is usually included at the bottom of the tracing because the leads are obtained at the same time. Only 10 seconds of sampling time is required to record all 12 leads. So only 10 seconds it takes to get all leads, the 12 leads printed on the strip. When viewing the 12 lead, keep in mind that leads that line up vertically are simultaneously recordings of the same beat. When you read the 12 lead from left to right, the ECG tracing is continuous. As you switch from one lead to the next, it's still continuous. I hope that makes sense to you. So no matter which one you're looking at, you're happening at the same time. So we're going to talk about some vectors. What exactly is a vector? A vector is a symbol representing the magnitude and the direction of an electrical force caused by depolarization and repolarization through the myocardium. Leads have a negative and a positive pole that sense the magnitude and the direction of the electrical force caused by the spread of waves of depolarization and repolarization through the myocardium. A vector, the symbol, the vector, points in the direction of the depolarization. Leads that face the tip or the point of the vector record a positive deflection on the paper, the ECG paper. So I'll repeat that. The leads that face the tip of or point of the vector record positive deflection on the paper. A mean vector identifies the average of depolarization waves, in one portion of the heart. You have a mean P vector. You have, it's a representative of the average magnitude and direction of both right and the left atrial depolarization. But you also have a mean QRS vector, and that represents the average magnitude and direction of both right and left ventricle. During a normal ventricular depolarization, the left side of the interventricle septum is stimulated first. Electrical impulse then travels the septum to stimulate the right side. The left and right ventricle are then depolarized together. Because the left ventricle is considered larger than the right ventricle depolarization forces are overshadowed on the ECG, which is why you see that higher peak on it. As a result, the mean QRS vector points down, that is inferior and to the left. So that takes us into looking at axials. Mean axials, average direction of a mean vector, only identifying the frontal plane. The axis of a lead is an imaginary line joining the positive and the negative electrode. The electrical axis refers to determining the direction or angle in degrees in which the main vector depolarized and is pointed. There is a triangle called Beethoven's equilateral triangle. It helps to form lead 1, lead 2, and leads 3. It looks like a triangle on a photo. It is. It's called Beethoven triangle. You see lead 1, lead 2, and lead 3. Beethoven law state that the sum of the electrical current recorded on these 3 leads, so lead 1, 2, and 3, equal the sum of the electrical current recorded on limb 2. The sum of the electrical activity recorded in lead 1 and 3, the sum of this equal to the sum of 1 and 3 equal to the sum of 2, right? Augment limb lead are added to the triangle. All right, so looking at an X-axial reference system, that's what that is called. is representative of all the frontal limbs. So this is a face, all of the limbs with the heart in the center, right? So you could assume the heart is in here. And if you notice, these are all the leads. 12 of them, if you count them, they're going to come out to be 12, half and half, right? And it's a 360-degree circle. The system forms the 360-degree circle surrounding the heart. The positive end of lead 1 is designated 0 degree. See it right here? The 6 frontal plane leads divided the circle into segments, each represented 30 degree. So if you add 30, 60, 90, and so forth. But remember now, you have negative on one side because it's a positive, and it's the negative. So down here is the pole, positive pole. Up here is the negative pole. So all degrees in the upper is positive and all in the bottom is negative. That's the picture. In this diagram that you're looking at on the screen, and that's just showing you, and you have the negative and the positive and just a triangle where it shows the sum of these two equal the sum of the equal to this. All right, so the figure depicts a vector from the limb leads in the frontal plane. Over here, B depicts the x-axial reference for determine the frontal plane axis. Note that the vector for lead 1, 2, and 3 are in the same direction as it is in A. How you know that? You look for these 1, 2, and 3. In the axial reference system, the axle of some leads are perpendicular to each other. Lead 1 is perpendicular to lead AVL. You see the line? That's a perpendicular line. What else? What else I could tell you about this? And lead 3 is perpendicular to AVR. If the electrical force moves towards a positive electrode, a positive upright deflection will be recorded. If the electrical force moves away from the positive electrode, a negative downward deflection will be recorded. If the electrical force is parallel to the given lead, the largest deflection in that lead will be recorded. If the electrical force is perpendicular to the lead axis, the resulting ECG complex will be isoelectric and or equiphasic in the lead. Note that lead 3 and AVL are positioned on opposite reciprocal sides of the x-axial reference system. So that's lead 3 and AVL. They're on opposite. See that? AVL. And where's 3? They're opposite. One up here. One is positive, one is negative. And that we're going to do 20 slides because this is a lot to take in. All right. So now we're looking at leads 1 and AVF. See lead 1, AVF. They're telling you the different, if it's positive, negative, right? They're telling you all of that. And let's take a look at what we have going right now. So determination of the QRX axial quadrant by noting the polarity of the QRS in leads 1 and AVL. Normal axials is seen if the QRS is primary positive in both 1 and AVL. So AVF. So if these two are mostly positive, that's when you see the peak look like this. The axle falls within the normal quadrant from 0 to 90 degrees. Right axis deviation, if the QRS complex is primary negative in 1 and positive in AVL. So if it's mostly negative in 1 and positive in AVF, then it's gonna deviate to the right. Left axis deviation. If the QRS complex is predominantly positive in 1 and negative in AVF, left axis deviation is present. If the QRS is primary negative in both the 1 and AVF, markedly abnormal like intermediate or northwest axial is present. And this is how they look. So how do you determine electrical axis? Let's look at this 12 lead EKG. Because the X-axial reference system is derived from the limb lead, then we will be focusing the lead shown in the 2 columns on the left side of the figure. So this is the left, right? And you could see 1, 2, 3, and then you're looking at AVR, AVL, and AVF. Look for the most isoelectric QRS complex in these leads. Iso mean equally balanced. Lead AVL shows QRX complex that most closely reflect our criteria. So when you look at them, they look normal. They all look good, right? On this right here. And that's the AVL. The patient QRX axis is perpendicular to the positive electrode in lead AVL. Look at the X-axial reference system diagram to determine which EKG is perpendicular to lead AVL. So you got to figure out which one is perpendicular when you look at the previous right here. Perpendicular. Let's go back. Lead 2, where's lead 2? Lead 2 is perpendicular to AVL. Now we know that the patient QRS axle is moving along the same vector as lead 2. Note the values associated with lead 2, right? In the axial reference system diagram, and it's at 120 degrees or positive 60. To determine if the QRS axle is moving in a positive or negative direction, look at lead 2 and determine if the QRS complex is primary positive or negative. Lead 2 is here. You will see that QRS is primary positive. You see that pointing up in lead 2. Therefore, this patient QRS is approximately 60 degrees. Oh, too far. At the top of this figure, you'll see the computer calculation. See them over here? And it's telling you the different calculation. The patient QRS is positive 56 degree right here. Our estimated at positive 60 was very close. So that takes me to the final slide. Acute coronary syndrome is a condition that people get, and this condition caused by a similar sequence of pathologic events and that involve a temporary or permanent blockage of coronary artery. The acute coronary syndrome include unstable angina, non-ST segment elevation, myocardial infraction. So that's a non-STEMI, they call it. And ST segment elevation MI, which is a STEMI. Sudden cardiac death can occur with any of these conditions. All right, so I am not going to continue into this 21 because this is a lot of stuff. And this is the most difficult thing for nurses. When you're a nurse, you don't have to worry about all of this, but it's good to understand some of it. For your quizzes and stuff, you need to understand how this works. So therefore, I'm going to stop here and then I'll continue on Thursday. Hopefully, you're all watching the videos. Have a good day.